Good evening to everyone present here with us today. This is Kriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Jaya Agarwal. Ma'am is MBBS, MD Pediatric, Consultant Pediatric Gastroenterology at Regency Hospital, Kanpur. With the help of ma'am and her wonderful insight, we will be taking a close look on today's topic, which is alert for neonatal cholestasis. Now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her. Over to you, ma'am.
Thank you, Sriyon, for the kind introduction. Good evening, everyone. I'll be talking about neonatal cholestasis and how it is important to diagnose this children's kids early and how it will help in the management and prevention of treatable etiologies. So, as you can see, the topic is alert for neonatal cholestasis. Let's first understand what is neonatal cholestasis. We all know that almost 10 to 15% of neonates present with neonatal jaundice, and most of it predominantly is physiological and unconjugated in presentation. What do we mean by unconjugated? As we can see, the neonatal jaundice is divided into two types of jaundice. One is unconjugated, and the other is conjugated. That is the neonatal cholestasis, which our is the main focus today. Unconjugated jaundice, in short, is predominantly caused by either hemolysis, which is either Rh-ABO incompatibility, or the extravasated blood in the form of cephalhematoma, inadequate feeding, hypothyroidism, breast milk jaundice, or rarer causes like Crigler-Najjar and Gilbert's. While the conjugated jaundice manifests with dark urine, that is yellow dark urine, acholic, that is white or pale colored stools, or pigmented stools as well, that is yellow colored stools, hepatosplenomegaly, and with abnormal liver function test. This group is named as neonatal cholestasis. And the significant thing is that conjugated fraction forms more than 20% of the total bilirubin on labs. It is less common than the physiological jaundice or the unconjugated jaundice we see in neonates, but is potentially dangerous. Why? Because most of them can land into cirrhosis if not diagnosed early and treated early. It is often misdiagnosed in the initial stages as physiological, and hence the children come very late when the irreversible damage has already set in. The cholestasis by labs is defined as elevation of conjugated bilirubin more than 20% of the total bilirubin if the bilirubin is more than 5. However, if the bilirubin total is less than 5, the conjugated fraction is more than 1, it is termed as neonatal cholestasis. This is the spectrum of neonatal cholestasis. As you can see, it is majorly subdivided into two entities. One is the extrahepatic entity, the other is intrahepatic entity. Extrahepatic meaning thereby the etiology is predominantly in the extrahepatic part of the biliary system, and the predominant causes are biliary atresia, choledochal cyst, and sometimes insufficiated bile duct syndrome as well. While the intrahepatic part is further divided into hepatocellular cholestasis, where the hepatocyte damage is the predominant manifestation in the initial phase, or in the biliary diseases, where intrahepatic biliary system is involved. Hepatocellular cholestasis causes, as you can see, are n number of causes, where idiopathic neonatal hepatitis constitutes the major fraction. And infections like TORCH, UTI, sepsis also cause that. Genetic metabolic disorders like galactosemia, hemochromatosis, tyrosinemia, and total parental nutrition associated cholestasis form the major causes. While in biliary causes, paucity of intralobular bile ducts, either syndromic or non-syndromic, and another newer variety which we are seeing increasingly is progressive intrahepatic cholestasis, is the intrahepatic cause of neonatal cholestasis. It may present later in life as well. Let's understand why this distinction between intrahepatic versus extrahepatic is important. It is important because The obstructive causes, which the majorly is constituted by biliary atresia, it requires surgery within 8 weeks of presentation, 8 weeks of life. And this not only guides the success, survival, and outcome of surgery and the prognosis of the child, and hence early surgery is mandatory. While in hepatocellular causes, some of the causes like galactosemia, tyrosinemia are very much treatable when diagnosed early or can be prevented with further damage like cirrhosis, where medicines will be the predominant treatment manifestation. Let's talk about neonatal cholestasis seen in India. Until 1990s or 2000, it was largely ignored with very little published data from India. There was no uniformity in approach to neonatal cholestasis. There is was and there is still lack of awareness among individuals, physicians, the patient population about the entity and the treatment modalities. There is lack of pathology and lab services in the periphery of the country. This is the data which was published initially in year 2000 by pediatric hepatology centers across India, who have shown that etiological spectrum of neonatal cholestasis in India is predominantly seen by idiopathic neonatal hepatitis or the biliary atresia. And for subsequently, the recommendations from this pediatric hepatology group published in Indian Pediatrics was to increase the awareness drive among the physicians and the patient population. There should be specialized centers with team of pediatricians, pathologists, and pediatric surgeon so that the biliary atresia can be diagnosed early and managed early. Prompt decision from the surgical intervention group is to be taken so that these children operated early, so with a better outcome, and ideally within 60 days of life. Uniform management protocol will help in prompt investigation and decision about the diagnosis and further management, whether surgical or medical. This was a protocol that was initially devised by this group of how to manage these children, which we'll be discussing in detail. And subsequently, there was a yellow alert campaign by Child Liver Disease Foundation in UK, where they have studied and distributed yellow alert packs in the population subgroups among the parents and the media. And the key message from this drive was if your child has jaundice more than 2 weeks with persistently pale colored stools, urine is dark colored, the baby should be urgently referred for split bilirubin, that is conjugated bilirubin blood test, so that the biliary atresia are diagnosed early. And what was the impact of yellow alert in UK that was started initially in 1980s was that the initial presentation of biliary atresia was around 9 weeks, which reduced to 54 days subsequently after the campaign, but it was subsequently still short of target of 6 weeks. However, the improvement was significant. This is a study over subgroup of infants in Taiwan where they use this stool color card. As you can see, the stool color card here signifies the abnormal stool colors, which is different shades of pale or white stool color, and the normal stool color urine of different shades of yellow and green. This implementation of stool color cards among the pediatricians and the newborn parents with the vaccination card helped in distinguishing of this children with neonatal cholestasis at early age. Almost 31% children of extrahepatic biliary atresia were diagnosed early because of this, and the screening resulted in their identification before 60 days of life, making a significant impact in their management. This is how pale and pigmented stool differ, and one should, as a physician, see the stool by themselves because sometimes parents say the stool is yellow or pigmented, but when you actually see the stool, it is pale. Coming to the investigation part of neonatal cholestasis, our aim is for early diagnosis of treatable conditions like infections and metabolic causes like galactosemia and tyrosinemia. We also get differentiation early of biliary atresia versus neonatal hepatitis so that we can refer early to a surgeon. As we were stressing every now and then about early diagnosis of biliary atresia and the surgery, why? Because there is influence of operative age on survival, on bile drainage of these kids. And this is a very beautiful study published in early 2002, which has shown that children who were diagnosed early within 30 days, or those who uh, diagnosed late and operated later in life, they had significant reduced bile drainage and survival as compared to those discovered early. And hence, one should emphasize on early operation and early surgeries of these kids. As a physician, how to approach once a child presents to a neo clinic with neonatal cholestasis. That means thereby that you have already done the liver function test. You have seen that the conjugated bilirubin is more than 20% of the total bilirubin. You distinguish at the presentation itself whether the child is doing well or it's a sick baby. This is a broad classification. Doing well meaning thereby no failure to thrive or any other symptoms. And most of the time, you will land up either with biliary atresia or idiopathic neonatal hepatitis. This is very contrary to the fact that such a rapidly developing cirrhotic liver disease has very well presentation at early end of life, and that is why most of the children present late, because for parents it seems everything is normal. One should wash the stool for 3 days subsequently by themselves, do a ultrasound, abdomen, HIDA only if the stools are ambiguous, and liver biopsy if required in the current scenario. However, if the baby is sick with failure to thrive and other symptoms, you are either dealing with congenital infections or metabolic causes, and here comes the role of blood and urine culture, TORCH screen, urine non glucose reducing substance, and alpha fetoprotein. Further dividing of about the not sick infants who present with jaundice and hepatosplenomegaly. And this is a slide for the pediatricians where you will see the obstructive cholestasis children presenting early with not sick state. And as I am emphasizing every now and then that the biliary atresia constitutes the major part, followed by choledochal cyst, where again the surgery is required. The only entity which doesn't require surgery at this stage is insipid bile duct syndrome. And this is seen commonly in children who have received multiple blood transfusion in the neonatal age, especially the premature children. And these recover mainly by the medical treatment, and the prognosis is very good. Neonatal sclerosing cholangitis is a very rare entity. The other causes where well child is there are bile acid synthetic defects or progressive intrahepatic cholestasis, where they may present with pruritus, Alagille syndrome, chromosomal disorders, or total parental nutrition also may lead to this issue. Now, coming to another entity where we see sick infants with cholestasis, how to classify and know which may be the differentials in the diagnosis. These children not only present with jaundice, they have hepatosplenomegaly. Some of them may have uncorrectable coagulopathy, edema, ascites, multisystem involvement, which can be in the form of fever, rash, anemia, and maybe the intrapartum or the antenatal stage of mothers may be having difficulty in terms of fever and rashes. The baby is low birth weight, small for date, or history of SIP deaths in the concerned baby. The differential majorly include the metabolic causes like galactosemia, tyrosinemia, and neonatal hemochromatosis. Infectious causes are herpes, CMV, rubella, syphilis, and toxoplasmosis. And last but not the least is HLH, that is hemophagocytic lymphohistiocytosis. This is the severe form of a disease which requires urgent treatment and sometimes bone marrow transplant as well. Since we are trying to distinguish biliary atresia from other hepatocellular disease because the diagnosis is imperative at early stage, these are the few clinical pointers and the lab pointers, which will help broadly in differentiating between biliary atresia versus hepatocellular disease. As you can see here, the IUGR and small for date variety is commonly seen in hepatocellular disease, and cataract chorioretinitis can be present in them. However, in biliary atresia, the hallmark is persistent acholic stool. If you have persistent white or pale colored stools with firm to hard splenomegaly, not sick looking child, an ultrasound abdomen showing gallbladder absent or with poor contractility, you are probably dealing with biliary atresia. HIDA scan only helps if it is excretory. That helps in ruling out biliary atresia. It is not helpful in diagnosing biliary atresia, but ruling it out. So if there is excretion, at least you are sure that this is not biliary atresia. A word about biliary atresia. It's a progressive idiopathic necro-inflammatory process which involves segment or all of the biliary tree. It is broadly divided into three types depending on the part involved, but the most common is type 3, which involves both right and left hepatic ducts, and the obstruction is at the level of porta hepatis. The treatment is potoenterostomy, which we know by the name as Kasai procedure. This is a very recent study published by Dr. Yacha from SGPGI and uh, Kalavati Saran Hospital in Delhi, where they have developed their own stool color card along with integration of urine color as well. And it has shown as a promising new tool for early referral where parents can easily distinguish between physiological jaundice and cholestatic jaundice with the distinction of urine color, as you can see here, and the different stool colors, of which 1 to 4 are labeled as pale, which will help in distinguishing diagnosis of biliary atresia early. However, the lower panel showing 5 to 7 stool colored, which are pigmented and normal and non-biliary atresia types. Future studies may further help in distinguishing if they are actually helpful and can be taken up at the primary care level. After this theory, let's deal with two case scenarios that I'll be discussing, which we see every now and then. 5-month-old male baby presenting with jaundice with diaper staining. This is very important clinical history that one must take. Whether the urine is high colored or the urine is staining the garments or diapers, that helps in knowing without the lab also that the child has cholestatic jaundice because urine color is normal in physiological jaundice. So the baby parents had noticed that the jaundice is there for last 3 months. Stool color, according to them, was pigmented, and there was progressive abdominal distension, which led for their presentation coming to a physician, which was very recent phenomena. On examination, the child was thriving well, had icterus. As you can see, the stool color, when on collection, we saw it was pale, white, completely white. And according to parents, it was pigmented. So here lies the discrepancy. On examination, there was hepatosplenomegaly and the liver was quite firm. His labs were done which showed deranged liver function test, and the hallmark is raised GGT, that is gamma glutyl transpeptidase, which suggestive of biliary obstruction. The alkaline phosphatase was also high. The prothrombin time was normal. Ultrasound abdomen showed hepatosplenomegaly and ascites. The liver biopsy was subsequently attempted after ascites control, and what we saw was widened portal tract, portal fibrosis, and bile ductular proliferation, which was very much pathognomic for biliary atresia. And since the child was 5 months old, we couldn't offer him a potoenterostomy, which could have led to his better survival and good prognosis. So this was a case of missed opportunity. Had he presented early in stage within 6 to 8 weeks of life, we could have offered him Kasai procedure. And this is a child who was lucky enough to receive the timely intervention with Kasai procedure at 8 weeks of life, and how he has developed over the years is a good follow-up patient. Another case scenario is of a sick child, 40 days male baby presenting with jaundice and diaper staining. As you can see, a sick children present early, and hence they are unlikely to be missed if diagnosed early, while biliary atresia presents late because they are not sick looking. So this child presented with jaundice and diaper staining with pigmented stools since day 3 of life. There was progressive abdominal distension since day 15 of life. There was poor feeding for last 5 days, and you can see there was a significant family history of two deaths with 85 days of age and 65 days of age, both presenting with abdominal distension and dying at early age. This was the third precious child which presented early. On examination, he had bilateral pitting pedal edema, bilateral cataract, as you can see here, and the hepatosplenomegaly was there. Stool color, as you can see, was pigmented yellow. So, most likely, this was a case of intrahepatic cholestasis. The labs showed deranged prothrombin time. He had low albumin, signifying how severe the liver damage was. SGOT, SGPT, though were marginally raised, the profound decrease in serum bilirubin was hinting towards metabolic liver disease. Urine culture showed E. coli, blood culture was sterile, and subsequently 3 urine non-glucose reducing substances were done, which were positive. This suggesting galactosemia, we went for confirmatory test, that is Gallic assay, that is galactose 1 phosphate, uridyl transferase assay, that is pathognomic to diagnose galactosemia, which was suggestive of galactosemia, and hence the diagnosis of galactosemia with UTI, urine tract infection, was made in this child. We started this child on galactose free diet. Prothrombin time was normalized with vitamin K supplementation. Liver biopsy was done subsequently, which showed micro and macrovesicular steatosis and with features of early cirrhosis as well, as you can see here. So the message I wanted to send across is that baby with cholestasis, pigmented stools, sepsis, cataract, and cirrhotic liver, one should consider galactosemia, because once you start the treatment, and that involves just avoiding the galactose in diet, you can see how beautifully this child responded to treatment. Within 3 months, his jaundice subsided, his ascites got controlled, and the cataract resolved over a year. His growth became normal. And with early recognition of this condition and the dietary therapy alone, we could salvage this child. So the take-home messages from my presentation for this neonatal cholestasis alert is, if you have a baby presenting with jaundice more than 14 days, do a conjugated bilirubin test so that you distinguish whether it's a cholestatic jaundice or a physiological jaundice which is extending to a prolonged phase. Suspect biliary atresia in well-thriving jaundice babies with persistently pale or acholic stools. If you have a sick baby with cholestatic jaundice, look for the treatable metabolic causes. Thank you all for patient hearing.
Thank you, ma'am, for your wonderful presentation. We do have some question if you like to take that up.
Sure.
So, ma'am, the first question from our audience is, when should a liver biopsy be considered, and what are the key histological findings and on in neonatal cholestasis?
So the liver biopsy is predominantly helpful in the initial stages for the diagnosis of biliary atresia. And the pathognomic features are widened portal tract expansion, and bile ductular proliferation if a good histopathologist is able to interpret them. It is primarily useful in that scenario where you can make early diagnosis of biliary atresia.
Next question is that, ma'am, what counseling should be provided to parents regarding long-term outcome of neonatal cholestasis?
So it all depends, the prognosis depends on the cause which you are looking for. If it is biliary atresia, diagnosed early, underwent portoenterostomy, which was successful, then the prognosis is quite good. However, if you have a metabolic liver disease which has not been diagnosed early, the cirrhosis has already set in, or even the biliary atresia diagnosed late, as I discussed in the case one, the prognosis is dismal. They may land in cirrhosis and then the outcome is poor. They may not survive beyond 1 to 2 years of age. And that is why one needs to identify them early and get it treated.
Ma'am, there's one last question. What are the
Yes, please.
indication for surgical intervention and when should be Kasai procedure be performed?
So, Kasai procedure ideally should be performed within 60 days of life if the child lab and the liver biopsy features is suggestive of biliary atresia. And can you repeat the question again, please?
Sure, ma'am. The question was, what are the indication for surgical intervention and when should Kasai procedure be performed?
Okay. So I have answered for the Kasai procedure. And the surgical intervention, other which is predominantly done, is in the failed Kasai procedures, biliary atresia, who present late or they didn't have drainage later. So these children can be offered liver transplant if they are not responded to Kasai procedure. The other surgical procedure is the biliary drainage procedures, which is coming up entity for children with progressive intrahepatic cholestasis. Rest others are managed medically.
Thank you, ma'am, for answering all our questions. That's all from our audience, ma'am. Before concluding, any take home message from your end?
So, the take home message is please help us diagnose early biliary atresia. Check for bilirubin levels, urine color, and the stool color yourself. Thank you.
Thank you so much, ma'am, for joining us today. With your permission, I would like to conclude today's session. Thank you.
Thank you. Thank you.